Good morning, everyone. I'm Dr. Steve Stites, and today we're bringing you a special Encore presentation of one of my absolute favorite episodes. Right now, our team is working hard behind the scenes to bring you more incredible stories when our live program returns in September. And if there's an urgent health update, we'll be here to bring it to you first. But for now, sit back and enjoy this Encore presentation. And remember, faith, hope, and science.
Good morning. I'm Dr. Sean Coomer, Chief Medical Officer for the Kansas City Division of the University of Kansas Health System. Welcome back to Open Mics with Dr. Coomer and our monthly edition of Show Me the Science. Every year, researchers with the American Cancer Society release their newest Cancer Facts and Figures report. It's a full, high-level data giving us 30,000-foot view of how many people in the United States are being diagnosed and dying from different kinds of cancers. This year's report includes plenty of good news. There's also some concerning takeaways. And today, we want to put some of this report into context. We've gathered expert physicians and oncologists to discuss the biggest headlines from their different specialties. At the desk with me today is Dr. Will Parker, urologic oncologist who focuses on prostate cancer, Dr. Kelsey Larson, a breast surgical oncologist, Dr. Ali Khan Naji is a thoracic surgeon who treats lung cancer and is the medical director of lung cancer screening. Last but not least, joining via webcam is Dr. Rayed Al-Rajabi, a medical oncologist focused on GI cancers. Great to have so much talent here at the desk and online. We know the COVID-19 pandemic caused delays in cancer diagnosis and treatment in 2020. The impact of those delays will be revealed gradually over many years. As screening rates recover, we went out into the community to ask people if they have been on top of their cancer screening since the pandemic.
I think I missed that 1 year in the early days mammogram.
It was scary to think about going into a place with a bunch of people that were, there for whatever reasons.
I was afraid. I was really scared to death.
I had a heart attack, February 2021, still COVID. Stayed in the hospital till March 10th. But it was all during COVID, and it was all scary.
And as you walk the halls, you would be able to identify what rooms were COVID patients because of the colors on the room.
Yep, you remember that, Doug?
I do, I remember that.
Dr. Larson, for breast cancer screenings, we usually focus on mammograms, and maybe you can touch on some of the new guidelines that came out this past fall with dense breast tissue. Do you think we're still seeing the effects of screenings delayed because of COVID-19?
Sure. We're slowly starting to get back into people being in their routine screening schedules when it comes to mammography. We saw a lot of delays really probably between 2020, 2023, but people are starting to get back in. We recently, this fall, you were mentioning, had some new information, new guidelines about increased screening for patients with dense breast tissue. So as patients are getting back into their mammogram screening, we're also trying to get the word out that for a lot of patients with dense breast tissue, about half of people who are getting screening, they actually need additional supplements. So that's where we're still trying to catch up, is on that supplemental screening.
Gotcha. So, Dr. Larson, one of the biggest headlines from this year's Facts and Figures report is that cancer incidence is down in men but rising in women. A lot of that is due to breast cancer rates, and the invasive breast cancer rates are rising. Let's take a look at what they believe is a factor. Excess body weight, a later age for your first birth, a decreased number of births overall. How do those factors connect to breast cancer?
Yeah, well, I think there's probably a couple things that are going on. First, breast cancer is most common in women in their 60s and 70s. So as we have an aging population, as we have more baby boomers that are getting to be that age, we're just going to simply see more individuals that have a breast cancer diagnosis. As you said, those other factors do play a role, so especially excess body weight or obesity, lack of exercise, as well as alcohol intake have all been associated with increased breast breast cancer, including in younger women. So we have sort of two things going on, both with the aging population and then our general population, some of those risk factors being pretty prevalent.
Yeah, so the quarantine and COVID-19 didn't help obesity, lack of exercise,
Correct.
drinking, et cetera.
Yep.
So, yeah, it makes sense. Dr. Naji, you run the lung cancer screening program, but only a fraction of the people eligible for low-dose lung CT scan are getting done. Who are these lung cancer screenings for, and why are they so underutilized?
So lung cancer screening has a good set of guidelines that's released by the CMS, age 50 to 80 years, having quit smoking in the last 15 years or currently smoking, and approximately a 20-pack year history. So what's a pack year? If you smoked 1 pack per day for a year, that's 1 pack year. So 1 pack per day for 20 years, that's 20 pack years. Half a pack per day for 20 years, that's 10. So that's how we calculate pack years. And those are guidelines that help us see, okay, who's eligible for a potential lung cancer screening. I think that a lot of this comes down to advocacy for your own health and also through your PCP. Good follow-up care, good primary care will allow you to get those screening questions done, just like they would do for a colonoscopy, for breast cancer, for whatnot. And I think that will help us get into more programs for lung cancer screening.
So big picture, lung cancer remains the leading cause of cancer death, but the cases and deaths are trending down, largely due to fewer people smoking. Are you concerned that vaping and e-cigarettes may undo the progress that we've seen from smoking cessation?
Definitely. I do believe that e-cigarettes and vaping could potentially reverse those effects, partly because there's a lot of inhalational things that you put in when you're doing that irritate the lung and potentially could cause major issues. Though lung cancer rates themselves are coming down, we're actually seeing them come down mainly for men, but not necessarily for women. There is, just like with breast cancer, there's a rise in women who have lung cancer. Part of that is due to the stigma that lung cancer has associated with it, not getting your screening, difficulty with managing the consequences thereof, but also women stopped smoking at a later time than men did. So we're seeing a kind of a delay in that curve in terms of plateauing for women.
Mm-hmm. There are plenty of people that get lung cancer without a history of lung smoking at all. Well, how does that kind of play out?
So the rates of those are actually increasing also. Historically, one would say about 15% of all lung cancers were from patients that didn't smoke. Unfortunately, we're seeing that number rise closer to 30%, 25 to 30% these days. There's a lot of environmental factors. I know patients are concerned about radon and things of that nature, but what we're seeing is just as our environment changes, the consequences of that change are seen in lung cancer.
Right, thank you. Dr. Parker, let's turn to you. All right. Prostate cancer is one of the most survivable cancers, but only when it's caught early. There's still some controversy around screening. Remind us what a PSA test is, and then is a PSA test alone good enough for cancer screening?
Yeah, so PSA is a blood test. It stands for prostate-specific antigen. It's testing something that the prostate makes for reproduction. And so anything that affects the prostate from a health standpoint is going to cause that number to start to rise. And of course, one of those things being cancer. It is a good test, not a great test. And so, we generally wouldn't say that PSA alone is good enough from a screening perspective. There are other adjuncts that we use, like digital rectal exam to feel the prostate to see if there's any nodules or tumors, and then other things like advanced imaging that we can do as well.
So it is a quantitative test, but sometimes it's qualitative. You're following a trend with PSA and more than the total number. Is that right?
Correct. So that's one of the hard things, and I think where a lot of the nuance is lost is that it is a quantitative test, and the interpretation of that number depends on a lot of factors. So for instance, age. A PSA for a man in their 40s is very different than a PSA for the man in their 50s and 60s, and so how we look at those numbers matter.
Okay, great. Another headline from the 2025 cancer statistics is that racial inequalities persist across the board. For prostate cancer, black men are twice as likely to die from prostate cancer compared to white men. Dr. Parker, what drives that disparity in prostate cancer?
There are a couple of things. I mean, one is us. We're part of the problem. So historically, a lot of the data in prostate cancer, and I'm sure in a lot of cancers, are racially biased towards Caucasian individuals, white men. And so our understanding of PSA for a long time has been based on population norms for men who look like me. And we know that that's not necessarily true for black men and men of other racial groups. Additionally, we know prostate cancers in black men tend to develop in the front or anterior portion of the prostate, which is not a part of the prostate we feel when we do rectal exams. So there's a natural bias in some of the screening tools that make black men more likely to present later with more advanced disease. And then, historically, as we know, there is some distrust of the medical community among black populations, and rightfully so for some of the things that were done in the past, that does also contribute to later presentation.
Okay, thanks for explaining that. Dr. Al-Rajabi, pancreatic cancer remains one of the toughest cancers to treat. 5-year survival for the most common pancreatic cancer is around 8%, pretty dismal. The new report shows that the incidence has increased for men and women by 1%. GI cancers in general can be tough, but what is it about pancreatic cancer specifically that is so deadly?
Well, as you mentioned, Dr. Coomer, the pancreatic cancers are very deadly. We diagnose about 60,000 cases a year, and about 50,000 cases pass away from the disease. So a very aggressive cancer with some limited options. The pancreas is a really deep organ in the abdomen and may not be very symptomatic. You won't have a lot of symptoms with it, but sometimes patients come in with jaundice or change in the color of their skin, and that usually is a chance to diagnose these cancers early. But unfortunately, unlike all of my other colleagues, there's no right way to screen for pancreatic cancer. Even with high risk family history, it's still very debatable on how to screen or prevent these cancers in high risk populations. But they tend to metastasize very early on in early stages. That's why they're difficult to treat.
Right, and you and I share a lot of patients in this arena, obviously, and nobody ever wants to be in our clinics, and I understand that. But much like black men with prostate cancer, pancreatic cancer presents very late and often metastatic, so that's more difficult. In your opinion, what can be done to improve the statistics around pancreatic cancer?
So I think pancreatic cancer is a very difficult cancer to treat, just like you mentioned. It really requires a multidisciplinary approach. This really needs the expertise of a wonderful surgery team, a medical oncology team, nutritional team. So there's a lot of people that will help patients go through a diagnosis of pancreatic cancer. And unfortunately, it's not a simple cancer to treat. It frequently requires very extensive surgery, heavy chemotherapy, and a lot of instances we require radiation. So there's a lot of collaboration to get patients through a diagnosis like that. So to improve our outcomes in the future, research is definitely the way to go in this disease, and hopefully with things like vaccines and targeted agents, we can push the results to even better every year.
So can you tell me a little bit about this PAC-MANN or Pac-Man diagnostic blood test? What's that all about?
Because we don't have a good screening process like colon cancer. Colon cancer has been a huge success in GI oncology, where we could decrease the risk of colon cancer with colonoscopies. Pancreatic cancer is harder to detect, and we've tried things like ultrasounds of the pancreas. We've tried MRIs of the pancreas, and even tumor markers, but they haven't really panned out in early detection. And this is a very aggressive cancer that could pop up in between screenings. So a lot of researchers have started to look at circulating evidence of cancer in the bloodstream, whether it's DNA or other modalities of detection. And this Pac-Man test is a new blood-based test that basically has about an 85% detection rate with the use of a cancer marker called CA19-9. It also has a very sensitive, it's very sensitive. So if you don't have pancreatic cancer, in 97% of the time it will be negative. So we are starting to see some of these interesting tests being developed that can be used in the primary care setting, especially if you have high-risk disease. If you have a family member with pancreatic cancer, a direct first-degree relative, you have a twofold increase in the risk of pancreatic cancer. If you have 2, it goes up to 7, and if you have 3, it's up to 16-fold. So those are the patients that we might need to think about, especially when there's a known mutation like a BRCA2 mutation in the family that definitely requires the patient to be seen actually in a high-risk GI clinic where specialists like me or some of our GI specialists can follow these patients on a regular basis.
That's great. Thank you, Dr. Al-Rajabi. We're here to answer your questions. Please send them in using the info on your screen. That includes the chat on YouTube or Facebook, or emailing the Medical News Network. Alexis Del Cid is watching for questions from our community. Dr. Del Cid, what do you got for us?
Oh, I like my new title. Thank
Anytime.
you. Stuart wants to know what cancers are best treated with immunotherapies.
You want to take that, Dr. Al-Rajabi?
Yeah, I'll take that. So we definitely have some rare forms of cancer that are best treated with immunotherapy. It's mostly patients with a syndrome called Lynch syndrome, and the use of immunotherapies is extremely effective in treating those cancers. We could potentially wipe out colon or rectal cancer that usually is common in Lynch syndrome with just immunotherapies. Immunotherapies are antibodies that attract your immune system in detecting cancers. And our immune system, once it recognizes cancer as something bad, is very, very effective in treating cancers. So those are usually the cases we look for in every single cancer patient at our institution. It's actually done automatically on every biopsy that comes back cancerous.
Marie has a question. Marie wants to know, she writes, I know you advise your patients to not smoke. Do you also advise your patients on avoiding any other specific carcinogens or pollutants? If so, which ones?
So of course not smoking, but from a carcinogen standpoint, vaping, e-cigarettes, anything else, anything that you're inhaling into your lungs that's foreign rather than just the normal air that we breathe, which is sometimes not great either, is not a great idea. So just introducing anything foreign into your body is not a good idea.
How about for breast or prostate cancers?
So smoking itself has not specifically been linked to an increased risk for breast cancer, but alcohol intake is. So we are actually very particular with counseling our patients. Women should have less than 2 to 3 alcoholic drinks per week. That would be an amount that would be safe maybe from a breast cancer standpoint. Smoking, vaping, e-cigarettes, all those things are actually really significant when it comes to surgical healing. So maybe not getting that increased risk of breast cancer, but when we see patients in our clinic, that's one of the first things we talk about because we need them to do their best to stop those things to give them a safe treatment for their cancer.
Thanks, Dr. Larson. Dr. Parker?
Yeah, prostate cancer is largely not considered an exposure cancer, so there's not something specific that we recommend avoiding. Obviously, we recommend avoiding smoking and the other things already mentioned. We do know there are some high-risk professions that have higher incidences of prostate cancer, like firefighters are exposed to a lot of things, and for whatever reason, prostate cancer rates are higher among firefighters. So that's kind of where it lands with prostate cancer.
Right. Thank you.
What gives you the most hope when you look to the future when it comes to treating cancer?
So I think we at the University of Kansas have a really robust research program, and we're very fortunate to have access to therapies that are still not available anywhere else. I think my biggest hope is really re-engineering the immune system and attacking the cancer in patients that don't have that Lynch or microsatellite instability profile. Trying to get your own immune system to attack the cancer and wipe it out is really what I'm very hopeful for. We also have the privilege to work with very, very cutting-edge targeted therapies here, and we've definitely seen a glimmer of hope, especially in tough cancers like pancreatic cancer. And I think there's a lot to come, and hopefully more options for our patients in the future.
I think what was mentioned there that's important is that we have been an NCI designated cancer center, but recently become even a higher level of a comprehensive cancer center designated by NCI. So that does give us some access to trials and new treatments, and to be on the cutting edge.
We've gotten this next question from a couple different people. And it is, do people in Kansas or Missouri have significantly higher rates of any specific type of cancer compared to the rest of the country?
We do see higher rates of lung cancer. Not necessarily, I wouldn't necessarily say it's an incidence or issue of that sense. It's just access to care. So what we're seeing is that we live in a very rural community, and though we are in Kansas City, the majority of the state of Kansas and major parts of Missouri are quite rural, and access to care is really the problem. So we'll see patients at a stage further along than we may have seen in a bigger city, or patients who have regular access to a primary care physician or just a specialist. So I think it's not so much an incidence issue; it's an access issue.
Great point.
Yeah.
Mary has an.
Go on. I was going to say, just especially in terms of breast cancer screening, it's the same thing. And as we know that for dense breast tissue, like we were mentioning, up to 50% of people have dense breast tissue. And so those are people who need access to increased screening to have similar outcomes in terms of their cancer care, early detection. It's just not possible to have at every location.
Mary has a question. Mary wants to know if there's any way we can reduce lymphedema by not removing lymph nodes routinely.
Dr. Larson, you might know more about that than most here.
Yeah, so one of our main things that we aim to do across breast cancer care and across a lot of specialties is safe de-escalation of treatment. So we are just on the start of having data come out that says when can we start thinking about not having to do as much in terms of lymph node surgery. So we're getting some early data back from national clinical trials that our patients had access to and participated in. The data is still new and still fresh, maybe 2 to 3 years in terms of follow-up. So across the board, we're not quite ready to eliminate all lymph node surgery, but that's what we're working towards. Right now, the best thing that we can do is offer people really proactive prevention strategies. And so anywhere that people get cancer care, including here, any high-level cancer center, should have a really great lymphedema prevention program. And so that's definitely something that we offer here. Again, something that is not possible in every rural setting. So some of our friends in rural communities are at a bit of a disadvantage, but something that we hope we can continue to roll out across the state.
Vera has a question. Vera wants to know, what is the screening for lung cancer?
So the screening for lung cancer is a low-dose lung cancer screening CT. As you can see here in the video, it's a patient undergoing this. It's a very quick, less than a minute scan, doesn't involve any contrast, very low dose of radiation, and essentially it's used in combination with a lung cancer screening program where you speak with a provider to go over the risks, the benefits, and what you may or may not find and what potentially we would do in terms of follow-up. So the fact that we have one of the largest, most robust lung cancer screening programs in the state of Kansas and in the region is a testament to what we can do for our patient population.
Well, this has been a great discussion. We want to get some final thoughts from our guests. Dr. Al-Rajabi, you want to kick us off?
I think with GI malignancies being on the rise, if you have a family history of colon, pancreas, cancer, I think those are the two that we always worry about. And you have any symptoms at all, please don't hesitate to discuss this with your doctor and be your own advocate. If these symptoms don't improve, keep going back until somebody figures it out. And please get your colonoscopies at 45. And if you're at high risk, talk to your doctor when to get those colonoscopies done.
Thank you, Dr. Al-Rajabi. Dr. Naji?
I think the big theme of today has also been screening and access to care. So I think I echo Dr. Al-Rajabi's statements of being a self-advocate for your health care, making sure that you do try to, at best, see a primary care physician, establish care, and work towards taking care of yourself.
Thank you. Dr. Larson?
Absolutely. Best thing that you can do, screening mammograms routinely start at age 40. It could be younger if you have a family history, depending on your family history. We also, and a lot of us in the Cancer Center, have really great high-risk programs. So if you have a family history, like Dr. Al-Rajabi was mentioning, of breast cancer, certain GI cancers, if you have that smoking history, we have programs where you can come in and be seen and get advice on what you need to do for screening. So you're welcome to come and talk to us, meet with us, so that we can help keep you safe.
Dr. Parker?
Yeah, I'd echo the advocacy piece. I mean, getting routine care, not just for cancer screenings, but just in general, is going to be what helps promote your health. I think also recognizing some of the screening tests we're talking about, not everybody is going to offer. So PSA being a prime example, there's some controversy that can exist in primary care literature about the value of doing that testing. And if you don't know, you may not realize you're not getting that test done.
Well, I want to thank everyone. I really worry about access. I worry about healthcare deserts out there. And, the state of healthcare these days, with all the pressures from vendors and payers and pharmaceutical companies, we're on the receiving end of that as a healthcare company and provider. As a result, some hospitals are closing out there, and it's become very difficult, and that's only going to increase the care deserts out there. So please take care of yourself, be an advocate. I want to thank all of our guests. I personally get to work with all these surgeons here at the desk, as well as with Dr. Al-Rajabi. They're fine people, fine surgeons and physicians. So please ask them and their colleagues. Thanks to everyone for watching and listening. Faith, hope, and science.
Subscribe to our morning medical update and open mics with Dr. Stites podcast. Now everywhere podcasts are available.